doing a separate analysis among men, a separate analysis among women to answer the question, is the effect of this exposure, is the effect of this treatment changing depending on the type of person you're considering? Does the answer change when you move from a male subgroup to a female subgroup? And since we're running a little short on time, let me give you an example just to try to drive this home. I'm going to go back to that same acculturation example. And again, this is the actual data we saw. 86 people self-identifying themselves as living a traditional lifestyle versus 382 identifying themselves as living an integrated lifestyle. Now let's suppose I divided people into subgroups according to their sex. And to make it simple, let's suppose that half of these people in the study were men and half of them were women. Likewise, half of these integrated people were men and half of them were women. So half of everybody in this study was a male, half of them were women. But when I divided my data set up into women, compared the 43 women living the traditional lifestyle to the 191 women living the integrated lifestyle, let's suppose these are the results I got. 4 of the traditional women were diabetic, and 18 of the integrated women were diabetic. Again, the prevalence of diabetes in each of these two groups is roughly the same, about 9%. So among women, it doesn't matter what lifestyle you practice. Your prevalence of diabetes is roughly the same. Your prevalence ratio is very close to 1. So if you were writing this paper up, you'd say that among women, acculturation status, traditional versus integrated, doesn't matter. They have the same prevalence ratio of approximately 1. But among the remaining people, if I took this table and subtracted it from the original table of everybody I started out with, I'd have the table of men, remaining 43 men who were in the traditional lifestyle, the remaining 193 men who were in the integrated lifestyle. Their prevalence would then become 46% and 21%. Now we get a different answer. Among men, lifestyle does matter. Men living the traditional lifestyle, they have a prevalence of disease which is twice that among men living integrated lifestyle. If I have no biases in this study, if I have no confounding by any other factor, what I have here is an example of effect modification. The effect of lifestyle, traditional versus integrated, is modified, is changing when I move from an analysis just using men, which show me a prevalence ratio of 2, to an analysis that just uses women, that shows me a prevalence ratio of 1. What that means is, if I have no bias, no confounding by any other factor, is that the answer depends on what gender a person has when you want to talk about the effect of a lifestyle. If you're talking about men, traditional lifestyle doubles the prevalence of disease. If you're talking about women, it has no effect whatsoever. It has the same prevalence ratio of 1. So think subgroup analyses when you think of effect modification. Essentially what you're asking is the effect of a factor the same or different depending on which group a person falls into. In this case, whether they're a male or whether they're a female. And in this case, the answer does change. It changes from a prevalence ratio of around 1 to a prevalence of ratio of around 2 when you move from a female data set to a male data set, a female subgroup to a male subgroup. So hopefully we'll talk more about confounding, more about effect modification, and maybe a little bit more about biases as we go on the next part of this lecture when we talk about statistics. But let me shift gears now just briefly, and I'm going to ask Erin to take over in a minute, because I'd like to discuss the exercise you were asked to think about last week of looking at the question of how we would design a study to see if being exposed or being enrolled in a telemedicine practice would improve your outcomes if you were a native Hawaiian or a Pacific Islander, and given the option of these two methods of care. So Erin, would you take us through the design that you guys developed, and then we can talk a little bit about it.
Hi, Fran, can you hear me?
I can hear you fine.
Okay.
Okay, hopefully everybody else can.
Okay, so I'm just going to be going really briefly over this study design for this particular project, and this was part of an administrative supplement that we submitted for an RFA that was related to telehealth and telemedicine. The overall goal of this project was to develop and test a model of culturally competent chronic disease management for type 2 diabetes And we were looking for something that could be delivered via telemedicine to rural and medically underserved communities of Native Hawaiians, Alaska Natives, and other Pacific peoples. And as you can see from our timeline, there will be 2 study sites, one in Hawaii and one in Alaska. In phase 1, we plan to conduct focus groups and also informant interviews to identify factors that may be important in designing a culturally competent telemedicine program for these particular populations. In phase 2, we're going to develop treatment and also cultural competency guidelines that will draw in part on recommended standards of care from the ADA and also from ACE, as well as data that was collected in phase 1. Finally, in phase 3, we're going to implement a pilot study to test the efficacy of the culturally competent telemedicine model in improving clinical measures and also access to care. And phase 3 will last for a total of 12 months, beginning with a 6-month accrual period and then a 6-month length of follow-up for each participant. Let's see, this is going to be a quasi-experimental prospective study design. We're not able to use either individual or site randomization, so the study is going to be implemented without randomization at 2 sites, one in Hawaii and one in Anchorage. And patients who choose not to participate in the intervention will be recruited as members of the control group. Let's see. A total of 94 participants will be enrolled in both the intervention and control groups for a total of 188 participants. And as you can see in the figure, we're recruiting Native Hawaiians, Alaska Natives, and also other Pacific peoples who are 18 years of age or older with a diagnosis of type 2 diabetes. We're going to restrict the study populations to persons with a hemoglobin A1C of 8% or greater. And study participants must also be taking at least 1 anti-diabetic medication and be a resident or client of the community served by the 2 clinics that are partnering with us on this particular project. The rest of the figure shows the flow chart of the intervention. So those enrolled into the intervention group will receive culturally competent telemedicine care from our research teams, while those enrolled in the control group will receive usual care from their existing healthcare providers. The last slide is the assessments that will be conducted at baseline, 3 months, and 6 months. And our primary outcome measure is going to be hemoglobin A1C. Our secondary outcomes include access to care, and we're going to measure that using patient surveys, as well as blood pressure and LDL cholesterol. And Fran, that's about the end of the study design.
Okay, let's spend the last 6 or 7 minutes just brainstorming, if we can, about this design. Erin, you had a great label for this. You called this a quasi-experimental design, yes. Correct? Okay. So, guys, in your mind, what does quasi mean when you talk about quasi-experimental? First of all, is this experimental? Remember I said the defining feature of an experimental study is you, the investigator, decides who gets your treatment and who doesn't get your treatment, if you're talking about a treatment trial, or who gets your preventive agent and who doesn't get your preventive agent. And usually that's done by randomization. Usually a coin is flipped. If it comes up heads, you get treatment. If it comes up tails, you don't get a new treatment. Now, as I heard Erin say, this design here, quasi-experimental, what they're going to do, and please correct me if I'm wrong, Erin, is you are going to approach the likely candidates for the study and give them a choice. They decide whether they want to be in the study and get telemedicine or not get telemedicine.
That's correct.
Is that correct? Right. So I heard you say that for some practical or maybe some other reasons, this was not going to be a randomized study. You weren't going to take these 186 individuals, flip a coin so that 94 of them were in one group and 94 of them were in another group. So what does that mean as you start thinking about what are you losing, what are you gaining by not randomizing? Remember these baseline factors that you're going to gather on people. There's socioeconomic information, their heights, their weight. You'll get body mass index from them. You'll get baseline hemoglobin A1C levels so you can see if they change over time. You're going to measure how much access is being to care, whether they have high blood pressures or high cholesterols. These are things you want to see if they change over time. But let's imagine you're one